Yeah, it's like the analogy of like, oh, I could just, go to Europe and get these medications. Germany, it's like
Yep.
less than $100 a month or something like that. It's like, yeah, you go to Germany or Italy or one of these countries, and you're also walking everywhere.
Yep.
You're eating healthier foods. You're living a very un-American lifestyle, and then you find out, oh, I'm dropping weight. I don't even need the medication after all.
Yeah.
So take that $20,000 and go on a summer vacation instead.
Yeah.
Of
And then rebound when you get back if you haven't had new habits.
yeah,
Even without GLP-1, 98% of people who lose weight tend to rebound if they don't change their lifestyle.
and I
That
like
is
the
making it.
third part of that where it says taking into account the needs of your individual patients. So if you have someone who has a need, let's say someone who has a specific plan exclusion for weight loss coverage, this is more and more common.
Yes.
I see it a lot with Blue Cross Blue Shield. I don't know if that's
And United,
reflective
not to call out
of
any names.
across like the nationwide trends, but anecdotally, that's what I've seen. So let's say someone has that and they have a need clinically to improve their health for one of these medications that
Yep.
does not cost $1,000 a month, then spending $150 a month on a safe, sterile, tested, accessible medication
Yep.
makes a lot of sense.
Yeah. So if you're one of the 95% of diabetics that's not on a GLP-1 that could benefit from one, all of those 95% of diabetics should consider one, even if it's compounded, as long as it kind of meets the first two criteria of quality compounding procedures and quality ingredients.
Yeah, because the sicker you are, the more the risk benefit skews towards benefit. So a diabetic with an A1C of 15, so it's off the charts. Like that has to get under control. The sooner, the better. Whereas if you have someone using this for, what they call the vanity weight loss, it's like, oh, I want the scale to be 5 pounds lower. And I don't want to do, anything else except take something that makes me not eat. I have a hard time seeing how that's justified. There's people out there prescribing it in that manner, but it just doesn't add up to me.
Yeah. GLP-1s, I would consider efficacious appetite suppressants, but not a good choice for an appetite suppressant. In regards to cost, we also found an interesting study that studied the cost, which was supposed to be a real world study, but it ended up being a very not real world study because they used GoodRx prices. So GoodRx prices for Mounjaro and Ozempic and Wegovy and Zepbound, they're going to be the exact same price per month, regardless of what dose you do. And basically, it's not sustainable for anyone. And it only gives you, give you like a 5% discount. So
Yeah, it's not
if
a
you can afford the
huge cost
GoodRx
savings.
coupon, like to stay on that for a year, what is that? $18,000.
Yeah, it's like the analogy of like, oh, I could just, go to Europe and get these medications. Germany, it's like less than $100 a month or something like that. It's like, yeah, you go to Germany or Italy or one of these countries, and you're also walking everywhere.
Yep.
You're eating healthier foods. You're living a very un-American lifestyle, and then you find out, oh, I'm dropping weight. I don't even need the medication after all.
Yeah.
So take that $20,000 and go on a summer vacation instead.
Yeah. And then rebound when you get back if you haven't had new habits.
Yeah.
Even without GLP-1, 98% of people who lose weight tend to rebound if they don't change their lifestyle.
Yeah. And it seems like, I think we did a whole podcast, or at least a segment of one, on the idea that people are not always rebounding when they go off of GLP-1. More than half of the cases, people are not. Now, they may be using other medications. They may be, getting compounded versions that are not picked up in the, sort of EHR databases. There's probably a lot of things going on there.
Because the insurance company does not want to pay for any maintenance dose of Wegovy under 1.7. They'll cover 1.7 and 2.4. So I always say 100% of the time, if you're coming off a GLP-1, you want to wean off slowly. And if your insurance company is not going to cover all of the low doses, then you're basically stuck with either samples, of which they're extremely hard to come by, or high quality compounded GLP-1. So we kind of recreated this trial, and we'll post their results up on the screen. That basically a little over a year costs $17,000 for tirzepatide, $20,000 for semaglutide. Again, that's not a real world study. And they had 1% of body weight reduction at around $1,000 to $2,000. Our examples that we'll also post up here, 1 milligram, about $12 a week of semaglutide, 2.5 milligrams of semaglutide is about $30 a week, but 2.5 milligrams of tirzepatide is about 11, maybe a bit more. The costs do fluctuate a bit. And 5 mgs of tirzepatide, which I would say of our patients, I don't know, I don't think I have a patient that's not a diabetic on 15 mgs Mounjaro or Zepbound or tirzepatide. Almost like the usual dose for tirzepatide is 5 mgs.
Yeah, and I think that's because our practice is also not just automatically setting people up on titration protocols. It's not like no matter what you do, every 4 weeks you go up on the dose, because we're not trying to spin out publications showing that, hey, we had people lose 20% of their body weight in 6 months or in 12 months.
Yeah.
Basically, it's slow and steady, tracking DEXA, lean body mass changes, making sure people are focusing on other pillars of health, not just looking at the number on the scale. But low doses do seem to be quite well tolerated and still effective enough. We do have the, I guess, sort of benefit of having a very motivated population.
Yes.
So I'm sure that can't be completely disregarded. But, to your point, yeah, I don't think that there's any patients that are maxing out tirzepatide unless they are type 2 diabetic.
Yeah, we have patients gaining lean body mass on low doses of GLP-1s. And a lot of people have great luck on 0.5 of semaglutide and sometimes even 0.25. 0.5 is about $5 or $6 per week. That is a pretty cheap cost per pound of body weight reduction. So I guess if you compare it to spending that money on a like slightly more expensive gym membership, it starts to be a better investment in your health if you're thinking about the beta cell production of your pancreas over a area of time. Even if you're just insulin resistant, not pre-diabetic, if from age 20 to 30 you were 100 pounds of body fat too heavy, then that is a lot of potential damage.
A lot of metabolic damage, loss of beta cells. You think about preserving those beta cells. You want more of those, not less of those, as you advance in age, because the pancreas generally is not going to improve in function, just like most tissues are not going to improve in function with age. Mm-hmm. So keeping, just like muscle mass, keeping as many beta cells around as you can seems like a pretty good idea.
Yeah. So I guess end-stage metabolic damage is actually diabetes, isn't it? Or end-stage is actually dementia.
The type 3 diabetes, as they call it.
Type 3 diabetes. That's an interesting thought.